Some parents do not get to decide the rhythm of their days. They live at the edge of elopement, meltdowns, lots of behaviors, screaming, stares from the people, and lots of questions as well. But behind every behavior, there is a child who's screaming for help. And behind every such child is a parent who's carrying a lot than you can think of. So today's episode is for all the parents who are living with children on the spectrum who are aggressive, non-speaking, with lots of behaviors, and who are misunderstood and feared as well. Today in the studios, I'm really humbled. I have someone I have been really looking forward to have in the podcast, Mr. Bahij Khozami. He is a BCBA and he specializes in autism. He did his majors from Massachusetts University and he has worked in the US, and now we are lucky to have him in Dubai. And I am really lucky to have him in the studios today. Thank you, Bahij, for coming and taking time out. There's a lot of questions. There's a lot to talk about since you're a BCBA and you know how much questions we have for you. Bahij, my first question would be actually the biggest worry that parents have. You go to a BCBA and you are told that your child needs ABA and OT and speech after the assessment. But then the resources come in, and usually many parents, since I'm into advocacy, I've been told they were told that take ABA because it's the top-notch therapy that can help you, and you can ignore speech and OT for some time. What's your take on that?
First, I want to thank you for inviting me, and glad to meet you. My take on this is, in general, whenever a person gets a diagnosis, the recommendation from the doctor will be the three evidence-based practices, which they are the ABA, the OT, and the speech. Many don't know this, is that the number of hours or what they need also depends on who did the diagnosis. For example, if the diagnosis of autism was done through a multidisciplinary team that involved ABA assessment, OT assessment, and speech assessment, and altogether they decided that this kid needs these three therapies, then the recommendation would be for the three therapies.
Yeah.
If the diagnosis was done only by a licensed psychologist or a psychiatrist or a neurologist or by one individual, which is not supposed to be like that, it's always two people and more for different reasons. If the recommendation was the three therapies and there is no OT assessment, no ABA assessment, and no speech assessment, then I would not take the three therapies blindly.
Okay.
I would check for each individual assessment, because when parents, they see that recommendation for the three therapies, they think more is better.
Yeah.
And sometimes more is not better. So when you do ABA alone and the kid needs OT, you're missing on OT when you say, I'm only taking ABA.
Okay.
Same thing goes for speech. If the kid has some speech issues and has some medical issues in his speech, like weak jaw, weak muscles, then ABA alone is not going to help. That's where a multidisciplinary team would be best practice to check if this three recommendation is valid or is necessary or not. In some cases, you don't need OT and you don't need speech yet. That means with ABA, because ABA is the science of human behavior. That means any behavior, including speaking, which is speech therapy, and language, those are all behaviors. So based on B.F. Skinner, language is a behavior. And OT, which is using your muscles, your hands, your body, that also involves behavior. So ABA does target these two, but not as in-depth as OT and speech they do. So when we don't have a kid who can follow directions, he's not listening, he's not attending, there is no scanning skills, there is no attending skills, he doesn't make at least a little bit eye contact with the speech therapist or OT, how is he going to learn these things? Most of the time we get referred kids who are going to speech, but they recommended ABA because the speech therapist was not able to work with him on her speech targets. Same thing goes for OT. They say go for ABA first, then come back for speech or OT. A lot of cases are like that. So to sum it up, I would say each practice has to have an assessment to determine what is needed and how much is needed.
So you think you can't say that one therapy can cover, ABA can cover speech as well? Usually, they say if you don't have enough resources, you can just take only ABA and then later see, if you can.
Depending on each case. So I have few cases here and in Kuwait as well where we only did ABA with the kid because it was determined that we did the speech assessment, we did the OT, and we did the ABA, and we determined as a team that ABA will be the first priority. So we did ABA. After 3 months, the kid started talking, and he was talking clearly. So there was no articulation issues, there was no speech. So we didn't need speech. Otherwise, we would have enforced speech on parents, pay extra. So I personally don't use that method where I have to sell you the 3 packages. Or I have to sell you 2 packages. Whatever is clinically recommended, I will give you that.
Okay. Yep. Yeah. And Bahij, the biggest struggle that I see as a mother with twins who are, moderate to severe is aggression. And I personally feel that is the side of the spectrum that we struggle with. The schools are struggling. Even the therapists I've seen, they're struggling. So and particularly I wanted to talk about self-injurious behaviors because that personally is my struggle as well. So what do you think, what are the main reasons for self-injurious behaviors? And sometimes as I was telling you earlier as well, sometimes they're just impulsive. I am looking around, that there's no reason why are they hitting themselves. So sometimes they're impulsive as well. So to you, as per your experience, what do you think, what are the main triggers that lead to, things as bad as self-injurious behaviors?
Very good. That's a lovely question. And I just want to start by differentiating between the definitions of aggression and SIB, which is the self-injurious behavior.
Yeah.
Aggression is towards other people.
Yeah.
SIB is towards themselves.
Yeah.
So if I am hitting another person, that would be called aggression. And there's a whole definition of that and different type depending on how it looks like. And then there's self-injurious behavior that is to themselves. So they're not hurting other people, they're hurting themselves. So there's a lot of misconception about aggression in SIB when I speak to parents. When I speak even to therapists, they say aggression. Then when I ask follow-up questions, it turns out that it's not aggression, it's SIB.
Yeah.
And vice versa. So I just want to clear that SIB is towards themselves that leads to physical injury.
Yeah.
Okay? So they hurt themselves to the point where you can see that there is damage to their skin, to their face, to their body, to themselves. So it's not just I did like this and that would be SIB.
Yeah.
Maybe that definition will not maybe that behavior will not meet the definition of SIB depending on how you define SIB. So if I do this, I didn't hurt myself and there was no physical injury. There is no red mark. There is no scratch. There was no sound. You didn't hear it. You didn't hear when I hit myself. So it depends on how you define that SIB so you can collect that data and see what's happening there. With SIB, the most common type of SIB the research has up to date is the head banging.
Yeah.
And head banging happens with toddlers as well, with children, with young children, out of frustration. And because they don't have yet the self-regulation skills, they usually outgrow it because they get that language later on and they do acquire that emotional regulation skills. Kids on the autism spectrum, on the other hand, we all know that they do have deficits and delay in emotional regulation skills, in language. It depends on the language. So there is no, these are learned behaviors. So SIB and aggression are learned behaviors. You're not born with them. You are not born with aggression. You're not born with SIB. You're not born with all the other behaviors. So they are learned behavior based on behavior analysis. Okay. How do they learn them? Through their environment. So there are a lot of reasons, medical reasons, psychological reasons, or what we call psychiatric. So for example, borderline personality disorder is a psychiatric disorder. They show similar self-injurious behaviors as autism. So they engage in self-hurting, but the intent is not suicide. So they would hurt themselves, they would cut themselves, they would burn themselves, like they burn their skin for some reason.
Yeah.
So those are SIB also, but that's not only in autism. So there are other conditions and reasons or other psychiatric conditions where the person will engage in SIB, and not only for autism. Many parents will say, "Oh, SIB, autism." That's not true. There are other conditions and cases where you can still engage in SIB. You can also engage in SIB if you got upset from someone, and you want to show your frustration, or you want to show them that you really, mean what's going on. You might hurt yourself.
No, but I am specifically talking about autism and SIBs.
Yes. So specifically autism in SIB, first we check medically.
Okay.
If there is any medical reason for that. And that's why I got this wonderful book, which is called Understanding and Treating Self-Injurious Behavior in Autism. And it's a multidisciplinary perspective. There's a lot of chapters that tells you about what could be the reasons, because it's not only one reason. So there's a lot of reasons why it happens. First, medically. We check if there's any medical allergies, dental issues, if there is any ear infection, if anything that is related to medical. Okay. If everything clears out and there is no medical problem or allergy or something like that, then we move on to behavioral.
Okay.
We don't treat behavioral first without knowing if there's something medical.
Medical condition. Okay.
Yes. And we can dive deeper with this, like, for example, headaches. So a lot of adolescents, children, or young teenagers, they reported that they have up to 40% headaches. They experience headaches.
Okay.
So there is a big majority of the reason is that they are having headaches. And they can't tell that they are having headaches. They don't know that they are having headaches because they can't tact the pain. They can't label the pain. They can't
communicate.
Exactly. So when I say to you, like, how do you feel now? You say, I feel hungry. You just labeled that emotion.
Yeah.
They don't know that they are feeling whatever they're feeling. Could be pain, it could be discomfort, could be frustration. So tacting, not just tacting emotions, tacting your own emotional state and recognizing your own body is a very important skill.
So I'll just ask you one related thing here. When they tell you that use PECs or use whatever form of communication they have when they are in pain or when they're in frustration. But I have personally noticed with them when they are aggressive or when they're angry, I'm talking about kids who are non-speaking, they will not even look at those things because, they are in a different state of mind.
Yep.
So all those strategies that are being told to the parents to deal with the SIBs or aggressive behavior, they don't work when that child is in pain or in a different state of mind. So that is where I struggle with ABA and the practical tips that you tell us.
Yes.
They will not work.
Okay. I will rephrase that. So when I put a program for PECs to teach PECs, we don't start immediately with teaching emotions. That's one. Second, anytime there is an emotional regulation skill to be taught, the first instruction to the therapists is to teach that skill when the children or the child is calm, not when he is at a heightened state.
Yeah.
Because as you mentioned, they will not respond in that moment, even if they have that functional communication skill.
Yeah.
So it has to be practiced, not only in the center. not
At home
only
as well.
during the ABA sessions. It has to be practiced across his day, across multiple people. It has to be his second nature to, when he feels upset, he goes to that picture and he takes that picture and he gives it to you as a way of communication. That's when he reaches that stage, and we want him before he reaches that heightened state where he is completely blank and can't do anything anymore, can't respond. We don't want him to reach that and then we say, okay, go get that picture. Before he reaches there, we want him to go take the picture and give you that picture where you can intervene before it escalates to that point. Now, as you mentioned, sometimes it doesn't work, sometimes it works. Most of the time it will work if it was implemented properly and extensively. And other times, even you can do everything and you have done everything right, is still you will have these moments where you can't get away from these type of episodes. But these episodes will be less. Instead of being more frequent, they will be less and they will be infrequent. So when they do happen, your only way is to just wait it out, have the kid calm down first, you calm down, make him safe, make everybody safe around you, and wait it out until it passes. And then you can start teaching or prompting him to use that skill that you're trying to teach him. Not in the moment you tell him, go get that picture, let me know what
When there's
feeling.
a meltdown,
When there's a meltdown, that means they reach the peak. You don't intervene at that point.
So
don't
you let
try.
them calm down on their own.
Yes.
That's what I do. Now I've learned it. Initially, you're asking them too many questions during a meltdown and they are completely zoned out. And then another struggle is another behavior that I've seen too much, even with my own kids. It's eloping. They love to elope. So the question here is it out of fun or distress, or it's some psychological need, or it's out of curiosity? Whenever they get a chance, they elope.
Yes. Many studies up till now, they couldn't pinpoint exactly what it is unless you do a functional behavior assessment, which tells you exactly why they are eloping, for what reason. Because sometimes the reason can be social and sometimes it can be non-social.
Okay.
That means they do it out of fun, they do it out of love, or it is social. That means when they run, they get something from that. So they are being chased. So I work with a kid, he loves to be chased. He loves it. As soon as he sees you attempting to run, you didn't run.
He enjoys
You know
that.
how you get ready to run?
Yeah.
He picks up on that. He picks up on your body language and he starts eloping. So what I did as a BCBA, I told the staff, do not show any attempt. That means don't make your body do this in an attempt that you're running, and see what happens. And the kid wasn't running. He was walking, looking back to see if somebody is running or attempting to run, and he saw the therapist is just walking casually. So he stopped running.
Yeah.
But we didn't just stop there, because that's not right. What we did is we played tag. So we gave him another way to access that activity or that feeling. If he likes to be chased, we are giving it in a proper setting, in a proper way. You know the game of tag?
Yeah.
So he was running, we were running after him, but we were running under our own condition and under a controlled condition, meaning that you're allowed to run in this place with these type of people in that area. It's safe. There is no exits. There is no, So
Yeah, because usually this is what I've seen. Parents will just go and grab them and, stop, don't run.
stop, exactly.
It makes them more curious. This is what I've seen. That
okay,
what is it?
You stopped it. What's the alternative?
Yeah, exactly.
Like, what did you give him instead? So you just stopped it. Then what?
Yeah.
But when you when you provide a replacement and a replacement that suits them,
Yeah.
they will stop that other behavior.
Yeah.
That if the replacement is not what we call function based, so it doesn't serve the same function as the elopement,
It
it's not
doesn't
going to
work. Yeah, that's lovely. And screaming. Do you think it's for the auditory sensation that they get? Because this is what I've seen with my own kids. I'm giving their example because I live these experiences every day. Sometimes they scream when I put a demand. Sometimes it's just nothing. I'm just looking at them. I'm like, there's no apparent reason, and I've seen that they'll giggle or they'll smile after that. So what I might be wrong, but sometimes I feel that they like their own voice. With non-speaking kids, I've seen when they scream, they enjoy their own, they enjoy it. So sometimes it's out of no reason, but sometimes socially it gets really difficult. A child sitting at a restaurant and he's screaming, and I've seen it too much. Screaming and vocal stimming. Sometimes, like these days, I say no to my twins, and they're like, they'll stim so loud, and I can see it's out of anger, like, why did you stop me? And the stimming will get so loud, and socially it's obviously very, very awkward. So what's the reason for screaming and shouting?
Okay. Any question any parent will ask about a behavior will have to be followed up by an FBA, a functional behavior assessment, to understand why. Otherwise, it's all assumptions.
Okay.
You know how you go to a doctor and you say, doctor, I think I have a headache.
Yeah.
Will he only treat you because of a headache, or he will tell you, let's do some other test? Maybe it's not just a headache. Maybe it's a tumor.
Test as
Maybe
well.
it's something more dangerous. So for us to find out the exact reason why he's doing what he's doing is for us to do an FBA. In some cases, we don't need an FBA. Only the ABC data will tell us the hypothesis, and then we can move on. So when that happens, also parents don't know that there are very, very, very subtle behaviors that kids with autism, they will pick up non-verbally. That means even a certain look, they will start learning that look means something to me.
Yeah.
Even
Yes, they're very smart.
a posture, even your movement, your body proximity to them, they will learn these things to act on. For us or for other people who are not behaviorally trained, it will seem like it's out of nowhere. So you will say it's out of the blue. I didn't do anything. I was just looking at him. I just put my hand on my cheek and I was looking at him. How do you know? Maybe that look and that cheek means something to him, and that's how he learned that every time you do this, that means you're
Angry or
whatever.
Oh.
So there's a lot of subtle behaviors that you have to be coached on, or because that's what we do with parent coaching. I one time called in the States. I said to a parent training. She was like, "You're training me to." That's why now I don't use training. I use coaching. So parent coaching is very important, because what we know usually the other practices and other people don't know about.
Yeah.
So when people say it's out of nowhere, there has to be something. The only time that we can say they enjoy it because it's themselves, it's self-stimulatory or self-stimulation, is when we leave them alone in a room that is not stimulating. It's quiet, no demands, just by themselves, and we're watching through a window where they also can't see us, and they still stim and do the vocal stereotypy. Then that means they like the sound of their voice.
Yeah,
Or
that's
whatever
my case.
they're getting. That's it. Other than that, it's all hypothesis. And it's not valid to say it's because there is some other stuff. No, the only time, that's why functional analysis by Brown Iwata is very important in these things. There's another study for Dr. Greg Hanley where they did target vocal stereotypy by using SBT, which is skills-based training. So what they did is they would have like a tray of things to work on, and the kid is sitting, and as soon as they present the tray for work, the stimming is redirected. It's not allowed. So the kid knows that this is not the time for vocal stimming. As soon as they bring back that tray or
He
that
starts stimming.
then you can stim now. You're allowed to stim. So they're not trying to eliminate the vocal stimming. They're trying to, and also I don't want to say control, but they want to, at least when there is something that involves learning, it's not interfering with learning.
So, what if a child is in a mall or at a restaurant? What are you supposed to do as a parent when the child is stimming really loud? And it's, I mean, really, really loud.
Yeah.
I'm sure you have seen. So, I like it that you said I don't want to use the word control, because I am a very pro stimming person because it helps them relax. But
Yes.
sometimes it's a little too much. So, as a parent, am I supposed to do with the child? If it's too loud and we are in public, am I supposed to stop him or redirect him?
Okay. Well, my answer would be you don't start at the mall. You start at home. You start at a place where you do know why he's doing what he's doing. If he's doing it because he is coping in this crazy environment, because maybe to you that environment is nice, you like the people, you like that environment, but maybe for him it's overstimulating. So what methods or what ways that we can provide him so that he can use those coping skills in a better way, or teach him a different coping skill rather than vocal stimming.
Okay.
But that doesn't happen at the mall. That happens outside the mall, and then you generalize it to the mall.
Yeah, I get that.
Yeah. So you don't. Many parents, they will say, "Oh, he's fine at home, but as soon as I take him in the mall, then he starts going crazy."
Yeah.
Well, that means there is something in the mall that is triggering that behavior. If at home he's fine and he's doing great with you, and then when you take him to the mall, then the behavior starts, then we have to see what's happening in the mall. Because now that might not be a skill deficit, that might be a place issue. So it's a generalization issue. If he can access his skills at home, but he cannot access his skills in the mall,
There's a problem.
that's a generalization problem. That means what he learned at home to calm himself down and to be okay with you, then we need to do the same in the mall. But when at home and the mall and outside and everywhere, it's the same behavior, that means there is either a skill deficit and environmental variables that we need to look at.
And also, I think what worked for me was exposure, because I see parents say that the child gets really out of hands when he goes to a mall, because they're taking him to a mall once in a while. What I did was generalization for me was taking them for 20 minutes to the mall. Then I kept increasing the time. And, just in first trip, I noticed, what is bothering them, the lights, the noise. Then I started picking up malls that were less busy, less crowded. I used to take them in the morning just to, get them familiarized with the situation outside the house. So yeah, generalization is the key. I truly stand by that side, because my kids used to elope, scream, yell in the malls in the beginning, but now, touch wood, I take them to the malls, they walk behind me. It's not 10 out of 10, they still elope, but it's better than before. So yeah, it does work.
That's really great what you mentioned. Sorry to cut you off. It's really great what you mentioned about you take them 20 minutes and you make it longer. In ABA, that's called shaping. So what you just did is an ABA strategy, and you didn't know that it was ABA. So a lot of people, and I think we will get to that topic, will say that we don't like ABA, we don't want to do ABA. I'll keep that question until I'll answer that when it happens. But yes, shaping will be in the plan. Exposure will be in the plan, but we don't do the exposure until we know that they have the skills to use for that exposure.
Ready.
Otherwise, you're just throwing them in there without the tools necessary to be successful. So it's great that it worked with you, and it's getting better. So that's awesome.
It's not perfect, but we'll get there.
We'll get there,
We'll
of
get
course.
there. And as you know, autism is like, it's too much now. I see autistic kids everywhere, wherever I go now. And with that, there is a rise in, the help available out there as well. I have seen parents who are too focused on diets. I've seen parents who are very particular about chelation therapies, about, name it, hyperbaric oxygen chambers, and medicine. This episode is particularly about aggressive kids and, SIBs and all that. Parents, the biggest confusion I see when the kids grow up, when they're younger, aggression is obviously manageable. SIBs are manageable. You can physically hold them. But when they're growing up, teenagers and aggression and SIBs, it's a very huge struggle. And the only option left for parents is medicine. But again, I've seen parents who use medicine and then they regret that later because it made things more worse. So as a BCBA, what do you think, at what point parents should say, okay, now this is the time, now you should move to medicine, or it's a personal choice?
Okay, that's a very, very good question. I always tell to my therapists, whenever they are working with an aggressive child, whether he's 3 years old, 2 years old, 4 years old, would you do what you're doing now if he was 14, if he was 20? Are you going to do the same thing as you do as if he was 20? So if you're picking up an aggressive child, are you going to be able to pick him up if he was 14? Probably not. So we use this type of strategies or way to reduce the aggression by not saying, let's wait. Now he's manageable. He's still a child. When he grows up, it will pass. Very common in many cultures. Because the kid is manageable, they think it's fine, let's leave it till later, or because they don't seek help, either they don't have the resources, either they don't have the financial resources, or they don't have the proper help. Whatever it is, you start when the kid is young, not when he's 14. So a lot of social media videos with parents with teenagers and adults that they are aggressive, if you dig deep in their history, you will see that they received no therapy, no kind of therapy. They didn't do anything. They just left the kid, because if the kid now is 20 years old, that means, he's at that time, there was not enough awareness about ABA. There's not enough awareness about behavioral therapy and all the other stuff. Now, lately, for the couple 5, 7, 10 years, they started this awareness more about ABA and about behavior analysis, at least here in the Middle East, especially Dubai. So when you leave your child and say he will be fine, or we can manage, he's okay for now, then your only choice will be medication when he's 14, 15 years old. That's one. Second, if you intervened behaviorally and you determined, as we were saying, that there is nothing medically, the kid is not in pain, he's not. So again, with SIB, also there are some hypotheses and studies that says that they give them sense of euphoria. That means when they engage in hitting themselves, it gives the pleasure hormone. They like it. It's like they just took a sniff or something.
Wow.
Yes. So not all cases. That's why now SIB is not one size fits all, and it's not the same. The latest study they did is in January 2025, and they found out that it's topography. That means how it looks like. It's not about SIB, substance use behavior. Okay, how does it look like? It could look a different way for different people.
Different people, yeah.
Okay. Now, going back to what you said about
medicines.
About medicine, when we take away the hypothesis from all these things and we are left with behavioral, if that behavioral didn't work for at least 3 months to 6 months, and based on data, because as you interviewed a lot of BCBAs before, so you know about the data. If the data determines that we tried everything and it's not working, that behavior is not reducing, then the medication combined with the behavioral therapy will have the ultimate result.
So there's no harm in trying.
Again, it's
because it's a big decision.
It is a big decision, but would you rather, like, we look at the quality of life of the person. Is his quality of life going to be better with medication or without medication?
Without medication, yeah. Makes sense. Yeah. And toilet training. Biggest struggle, biggest question. Everyone is struggling. I get this question a lot. I think it's the most biggest worry that parents have. So is there any toilet training protocols in ABA, or what does a toilet training plan looks like to you? And I really wanted to mention it because I see a lot of programs where kids on the spectrum are being excluded because they're not toilet trained. There are a lot of special schools that are not taking them just because they're not toilet trained. Yep. So what quickly can you tell the parents about toilet training who are really worried and who really want you to answer them?
Okay. I hope this sentence will be a very big impact on them. Toilet training is like a war.
Yeah.
And you have to win the war.
Yes.
It's not a battle because the battle can finish very quickly. But a war will last long.
Yes.
So it does take a long breath to go with toilet training.
Yeah.
And the recommendation, there are different books and different ABA strategies for going about toilet training. But the most common one is, I believe it's Asdeen, Risley, and Asdeen, if I'm not mistaken with the names. So that is one. Another one is a little bit more relaxed, and you start early. Again, early is the key. Everybody talks about that for a reason, not because that's the only thing we have to say. It's just because that's what really matters. So the earlier you do the toilet training, the better. Now, there are some prerequisites when it comes to toilet training. We can't just only rely on age. Yes, your kid is 5 years old, but he's not functioning at a 5-year-old age.
Yeah.
Yes, your kid is 3 years old, and at that age they should be toilet trained, for example. But he's not ready because he doesn't have the skills or the prerequisite skills to be toilet trained. So when you try to toilet train your kid, you're going to fail, most likely. And when parents attempt to do the toilet training for their kids with autism by themselves, most of the time, the kid will start associating toilet training with something bad. So when we come to do the toilet training, already the kid has behaviors in the toilet. He doesn't like the toilet anymore. He doesn't sit on the toilet anymore. Every time he goes to the bathroom, there's a struggle. There are behaviors. There is aggression. There's a lot of stuff happening because he associated already the toilet with aversive, with a bad experience.
Yeah.
So now we have to redo everything, reshape, do a lot of stuff so that he can first accept the toilet before we start the actual toilet training. Can he hold his bladder? For how long? So there's data involved. Can he communicate if he wants to go to the toilet? How is he going to tell you I'm going to the toilet? For example, let's say he's in the classroom. He doesn't have a way to communicate to you. He cannot, or he doesn't know how to take a picture and tell you toilet or give it to you, or sign toilet or say toilet. How is he going to ask to go to the toilet? Most parents, they say, I know when he wants the toilet. Okay, how do you know? From his body language. He will start doing XYZ.
Yeah.
Okay, but does the teacher know that? Do other people know that? What if you're not there? How would people are gonna know that he needs the toilet?
Yeah.
So there are some prerequisites that needs to be there before we start toilet training. That's a very short summary of everything.
So you can toilet train. It's not like...
Definitely. Who said we cannot? Definitely you can toilet train. And another thing that I will also say definitely is improvement, is progress.
Yeah.
There are many things that we cannot guarantee, but we can guarantee progress when it involves proper ABA and doing it properly. I have very different cases, not autism, Angelman syndrome, Rett syndrome, not just autism. And the progress for these kids might look like it's very far and impossible.
And slow.
And slow. It is slow. And the first thing that I said to the mother, I said, yes, it is slow, but we will make progress. And we did. It did take us longer, yes. But we did progress, and she saw the progress, and now she's
baby steps, basically.
Definitely.
Baby steps. We're running out of time.
Yes.
These 2-3 questions I really wanted to ask you. That inclusion, I have seen, we're living in a country that is trying to be the best when it comes to inclusion, but I still see inclusion as selective and performative when it comes to kids with, high behaviors, non-speaking autism. Inclusion is a struggle, and inclusion, even in mainstream schools and societies with kids like mine, is still a problem. So how can we manage that? How can we, because I'm sure you have seen events having kids who are on the spectrum, on the, lower side of the spectrum. I don't know if there is any such term, but, who are doing better. You don't see kids with very loud stimming or lots of clapping or jumping around on events. The kids I've seen on events are very calm, and I don't see representation of this side of the spectrum too much. What's your take on that? Why it's still not happening?
Okay. I will start by saying, and maybe not a lot of people will like what I will say, inclusion is not for everyone.
Okay.
It's not for everyone. Because when you try to include certain children that lack certain skills, you are doing a disservice to them. You're not helping them. Because if they learn through observing other people so that they learn through other neurotypical children, then it's okay. But if you have a kid who is not able to learn through that method, then you are doing a disservice to this kid and to the other kids. Because I know, and I'm sure that you know, no parent wants to have a classroom that is aggressive, that is not safe for their children. There's a chance or potential that their kid will get hurt in the classroom. Nobody wants that. And schools are also, I don't know if we can say that, it's also politics. So they also don't want these type of behaviors to happen in the classroom for the safety of others.
So you can say they're not well equipped. They're not well equipped or not trained to manage kids like.
Yes, and they're not supposed to, because this is not their job. So that's why having them included in a general setup is not for everyone until you have the tools or the skills for the child and for the teachers and the staff to handle together. Otherwise, inclusion is failing or will fail, and we've seen it.
So sometimes I say this to my husband as well. I don't know if it's legit to say, or I don't know how much am I going to get bashed for this, but I feel the kids who are on, who are severely autistic, I'd use the term, maybe we have malls or spaces that are particularly designed for them, because parents are struggling as well, and it's psychologically affecting the families as well. You can't, like you said, you can't take a child out because it's a problem for everyone, and then it ends up in a lot of frustrating situations. So maybe we can have a mall that's particularly for people of determination, where there is no judgment, no eye rolls. Like truly, sometimes I think on those lines as well.
Yeah.
Why not? I mean, we are talking about solutions here.
Yes, but what's a better solution? Getting the proper help. Because it does exist. It used to not exist. And that's what parents of older children are experiencing.
Yeah.
And they are still experiencing until up to date, because their BCBAs worldwide, only 75,000. BCBAs registered with the BACB, only. Imagine, only 75,000 BCBAs worldwide. That's not enough for what's happening. That's one.
Yeah.
Second, people are not used to calling behavior analysts for behavior reasons. Now, everybody is an expert in behavior. OT is expert in behavior. A speech therapist knows about behavior. Everybody will say, yes, they do know behavior in their lens, psychologist, as teacher, these stuff. So to summarize it quickly, when you start accessing help and proper help from a BCBA who knows or how to reduce these behaviors early on, parents don't have to struggle like you're saying. They don't have to find places where, for now, very difficult to exist, and you will have challenges. It's better to work on these behaviors early on with the proper support and the proper help.
And we need to have more BCBAs.
More qualified BCBAs, not only passing the exam.
Yeah. Lastly, because we're running out of time, what do you think, what should be the course of action for high needs autistic adults? Because I have seen that there is help for children, but for adults, parents are worried. I mean, my kids are 12, they're going to be teenagers and then adults, inshallah, in the future. And I'm worried for them. So what do you think, what could be the course of action for children who might need support throughout their lives, or who might stay non-speaking, because 25% of the kids on the spectrum might not speak, and this world is not very easy with kids or adults who can't speak.
Non-speaking doesn't mean non-communicative.
Yeah.
So if they do not speak, that's fine. There's a lot of other conditions where they are mute, they don't speak, like Angelman syndrome. They don't,
Yeah.
they will never ever speak, no matter what you do. It's just that's the condition.
Yeah.
But when you give them the tools to communicate, they can communicate properly.
Yeah.
So to answer your question, it's
So
I lost the train of my thoughts.
yeah. No, yeah, there's a lot
There's a
going
lot
on
going
in
on
your
in my
head.
head right now. I wanna say.
High needs autistic adults, support for them. You think rehab centers?
I don't think so, and especially in Dubai. In the States, if you look at the statistics and the numbers, the cost for caring for an adult high need autistic child is in the millions per
Wow.
year, and thousands per person. Thousands. It becomes millions for a lot of people.
Yeah.
So that's why they have group homes. They have residential places. We don't have these things here, at least yet. And I know only one place that has that type of residential.
Yeah.
And I'm not sure, like, I don't have the details on that as well. If they do have, like, what's the age gap, what's like that. So, yes, it definitely needs a resource for that. And it takes a lot of, resources, not just professional resources. It takes financial also to get the proper place, to establish it well, to have the proper team.
But we need to have them, because otherwise, what's the future? I mean, parents are the main caregivers. Hopefully, the siblings will be, but we need to have them, and I'm hopeful that Dubai will have, because we are on the right track. I
Yes.
see,
Yes.
and bless this country that's trying
Definitely.
real hard.
Absolutely.
And lastly, one message of hope as a BCBA to the parents who have kids who are non-communicative. Yeah, like you just corrected me, on the aggressive side, and who will need support maybe throughout their lives, and parents are worried. What's your message of hope to all of them?
My message of hope is there is always hope.
Yeah.
There is always hope. There is always a way. And there's an evidence-based way to do that. You don't have to go through a rabbit hole, because now these days a lot of people and a lot of professionals, they are taking these parents through a rabbit hole. And they're not getting the results, and they're getting drained financially, and they're not getting the results. The thing about evidence-based, whether it's OT, speech, or ABA, it takes longer.
Yeah.
We know that. That's also, if you ask me personally, what I don't like about what I do is it takes longer to show the results, rather than going into a machine pretending that there's something happening there, and then the next day or within a week you see a little bit improvement. How do you know it's from that type of therapy? How do you know?
Yeah.
You don't know. Maybe it just happened, or maybe you're doing something else and it caused this. But the parents will give the credit not to the ABA or the evidence-based therapy. They will give credit to the other one, which is the, let's say, I don't want to say diet, because diet also plays a big role in when it comes to aggression and SIB. That's why I said first, medically and biologically, we have to check if everything is fine. They don't have inflammation, they don't have toxins, like all these other stuff, bacteria, candida. So that, along with the behavior therapy, is the best outcome. But when it comes to if you don't check on these, then you will have these.
So you recommend medical intervention. You think that parents should, before coming to you, they should get all these tests done for candida and inflammation and everything, because that's a confusion as well. These tests are very expensive.
You're right. It is expensive, but if you really want to get a full picture, and we give you the best plan or the best intervention, we need to check these things first. As a BCBA, my ethical board does not allow me to give you or tell you non-evidence-based practice. So only telling you go do this test and do diet intervention alone is not ethical. It's not recommended. But because I have seen personally some cases where they did improve behaviorally through diet intervention alongside the behavior intervention, now I believe, and it's not a single cure. It's not a standalone intervention, which is the diet and the other stuff.
So it's a multidisciplinary.
It's a multidisciplinary, but the first one I would say is the ABA.
Maybe.
I would not, because like I said, ABA is everywhere. You don't know you're doing ABA.
Yeah, exactly.
And
Exactly.
teachers and students and business owners and employees, everybody does ABA every single day.
And there is no age. Like some parents are concerned that ABA doesn't work after 10 years, or you're too late if you're starting after 5 years.
No.
So there's no age.
Definitely
You
not.
can start at any
There is no
time.
age. I mentioned recently in a video 350 domains ABA was used other than autism. 350. They used ABA strategies and principles to train astronauts to go to the moon
Yeah.
by using task analysis, by using reinforcement, a lot of stuff. So it's not only for ABA.
Yeah.
Oh, I don't want to do ABA. I want to do other stuff. What other stuff? Everything else they're doing also includes ABA. They just don't know what it's called.
It's everywhere. ABA is everywhere.
Everywhere.
So, Bahij, if anybody wants to reach out to you, how can they reach out to you? And I hope you're reachable, because BCBA is also a big thing, as we know. So if anybody has any question they want to ask you, and I'm sure there'll be a lot, how can they reach out to you?
I'm very reachable, and I'm not sure about others. They have their own reasons, but I'm very reachable. I am here to assist as much as I can. So one thing that is good to mention is that I have my own center, which is Autism Intervention Specialists
Okay.
in JLT in Jumeirah Lake Towers. They can contact us through WhatsApp, call us, or by email, or by visiting the website. I'm not sure if anywhere that would be, or I would say the number.
No, I will just
Okay, you can
put
say.
it in the subtitles.
Excellent.
And thank you so much for coming, and it's a pleasure. It's never enough time to talk to a BCBA because you guys are so rare, and it's really difficult to get your hands on them as well. But again, I'd say if you have navigated through meltdowns with grace, every moment you stayed strong while you were crying inside and screaming inside, you should be proud of yourself as a parent. I know it's not easy. I am sitting here. I have twins who get aggressive, who have self-injurious behaviors, but I take them out everywhere because, as I've always said, we and our kids on the spectrum, regardless of where they are on the spectrum, we have full right to life. So wear your crown every day, be proud, because what you are doing, raising a special child with so many issues and difficulties, you are a warrior without an invisible cape, and you should be proud. And you wanted to add something.
Yes, I just want to add to what you're just saying is that the number one predictor of success of kids with autism is their parents. Studies are showing that parent involvement after 2018 started increasing, and the results are getting better through these research. So parents are the key. The mental health of the mother and the father is the hope that we're talking about. Because if the mother doesn't have the mental strength to go through this journey, then the whole house will collapse. And I've seen it personally recently with a family that the mother was not mentally ready for what's happening, and the kids were not receiving proper consistency in therapy. She was lost. She didn't know where to go. Even with guidance, she was still in denial, and she couldn't handle the fact that this is happening to her. So the mental health of the parents are very,
That's the
very
key.
important. So I really admire your strength, because I follow you, I know. So that's, we have to give hope for everyone, because there is hope.
Yeah. And to all the parents listening, like Bahid said, you will get there. If you have just started your journey, I know it's not easy. It's like a roller coaster ride, but mental health is important. I've always talked about it. Take care of yourself, because you are the leading light of a tiny angel in your life, which is a very important job that's been given to you. So tons of love and tons of power to you in this journey that's not easy, but you'll get used to it because there's no other option. So I'll see you in the next episode of the Warrior Mommy podcast, and I hope today's episode was informative. I really enjoyed it, and thank you so much, Bahij, for
Thank you
coming.
so much.
It
Me
was
as
a
well.
pleasure.
Thank you.
I'll see you all in the next episode. Bye.